all have requested me to say about the changes. So really quick, guys, what is going to happen that the USMLE Commission has came together yesterday, and they have decided to do the following. They have increased the passing score from 194 to 196 starting at the 26th of January, okay, next year. So what that means, if you get a score more than 196, you will get pass. Will you get an actual score? The answer is no. You will not get an actual score. If you get lower than 196, you get fail. That's it. Are they going to change the difficulty of the question? The answer is no. The question will be with the same difficulty, with the same material. Are they going to, what is the percentage of people who are going to pass? The percentage of people who are going to pass are 96% of all people who will do the exam. Okay, so is it a good time to do the exam? It's a perfect opportunity to do the exam. Why? Because now you have 96% chance of passing it. Sorry, after this date, you have 96% chance of passing it. What about now? What about if you do the exam now? There is 98% chance of passing it, but there is high chance, 50% chance, that you are going to get low score, lower than 220. And if you get lower than 220, there is high chance you will not match because you will be filtered out. So now you have a really high chance of passing this. So please, guys, don't spoil it. Do it. Let's finish up with this. Let's study a little bit harder. So we'll get all of you done with this, and none of you will have to do it after June. Why I'm saying about June? Because in June, they will have one more meeting on the 30th of June, in which they will decide if they want to basically change the system again, rise the passing score. So it's going to be 196. They might rise it to be 220. You don't know. So it's the best period of time to pass it right now, not to postpone it for later. Okay, guys. So after finishing with that, I hope you have a little bit of motivation of finishing this exam. And today we are going to speak about immunology. So let's take a look. Today we are going to speak about the primary immunodeficiency. When I say the word primary, it means it's a form of immunodeficiency that you are born with. So you got it from birth. You got it from your parents, from mother, from father, it doesn't matter. You get it from birth. But if we speak about secondary immune deficiency, you get it as an adult. Can someone tell me an example of secondary immunodeficiency? Secondary. HIV, excellent. HIV is an excellent example of secondary immunodeficiency. About a primary immunodeficiency, the answer is all of these. So starting with we have they speak about the B cells, they speak about the T cells, they speak about the combined diseases, which mean B cells and T cells, and finally, we have the other stuff, which is basically problem with the neutrophils or some other process. Keep this for later. But for now, remember that your acquired immune system contains a lot of lymphocyte. These lymphocytes have two types, T lymphocyte and B lymphocyte. Yeah? The T lymphocyte had two types, if you remember, the CD4 and the CD8. And the B lymphocyte was basically the one responsible of making you plasma cells, which made you the what? The antibodies. Yeah? Okay. So now today, first of all, I will be starting with speaking about pathology relating to the B cells. What will happen to you if you have no B cells? If you have no B cells, will you have antibodies? Yes or no? No antibodies. So there is a disease called X-linked Agama Glubulinemia, and the question starts like this: why it's named Agama Glubulinemia? What is this? Well, plasma proteins. Inside of your plasma, you have a few proteins you should know about. And basically you have your alpha protein, your beta protein, and you have your gamma protein. So main protein of your blood is what? Is albumin. And albumin used to control which pressure, guys? Which pressure used to be controlled by albumin? Oncotic pressure, excellent. So I just sent you guys a picture. Take a look at it here. So you can see if you do an electrophoresis of the proteins inside of our blood. Remember, a blood contains RBCs and the plasma, yeah? So the plasma, it has what? Water and the protein. These are the proteins. So you have mostly albumin, as you can see. You also have alpha 1, alpha 2, and beta. I will be speaking about each one function when I speak about its disease, yeah? So for example, when I speak about alpha 1 antitrypsin deficiency, I will be speaking about this one, okay? When we are going to speak about Wilson disease with increased ceruloplasmin, I will tell you that this one will be increased, okay? When I will be speaking about hemochromatosis with increased transferrin, with decreased transferrin, I will tell you how the beta will be going down. But the gamma here, see the gamma? Gamma represents your immunoglobulin, which is basically your antibodies, okay? This is good. Okay, which is basically your antibodies. So the antibodies in your circulation are represented by the gamma globulin. Guys, can you give me a disease in which we have a ridiculous amount of gamma globulin? Well, you are good, but it's not the disease that well, you confuse me. Amyloidosis it can be, but it's due to multiple myeloma. Okay, multiple myeloma can lead to amyloidosis, but the thing that is leading to the gamma spike or the M spike we call it is what? Is the multiple myeloma. Remember, in a disease called multiple myeloma, it goes something like this. Yep, it goes something like this. In multiple myeloma, the patients are suffering from what? They have a ridiculous amount of light chain production of the immunoglobulin. I hope now you know what is a light chain. Remember, an antibody has what? This is an antibody, yes? It has heavy chain, yeah? And it has a light chain. So this is the heavy chain, and this is the light chain. So they have a lot of basically antibodies and a lot of light chain. This light chain will create for you the M spike, yeah? Also, they will create for you what? They will create for you risk of amyloidosis due to the deposition of the, you guessed it, the light chain. Good. So, let's keep going. In case of in case of protons gamma globulinemia, what will happen? So, see this gamma thing? It will disappear. It will be non-existent. Basically, because you do not have antibodies. Yeah, it will go away, simply. So, just imagine it as becoming flat. Why? Because you don't have gamma globulins anymore. Because you don't have antibodies anymore. And yeah, that's important. So if you don't have antibodies, you will have more risk of bacterial or viral infection. Mainly because it could be some other stuff, but mainly bacterial. More bacterial infection. Absolutely correct. So when you take a look here, there is a defect in something called Bruton's tyrosine kinase. Okay, Bruton's tyrosine kinase, a tyrosine kinase gene, which will lead to you to have 0 B cells maturation. So you will have, it's an X-linked recessive disease, which means it has an increased risk in boys. Why? Because if a disease is X-linked, this is a man, this is a lady. If the man has, but can't they still have some IgMs? They do have some, but look, in general, they don't have mature B cells, okay? If you don't have mature B cells, it's true that the naive B cells have IgM, but the IgM will be stuck into the cell. So remember, the naive B cell have IgM and IgD, which will be stuck on their walls, yeah? After IgM and IgD. So yeah, it does exist, but is it in the circulation or stuck into the B cell? Well, it's stuck into the B cell. It will not be free into the circulation. To get it free into the circulation, the B cell has to maturize. So when you have a mature B cells, the IgM can be released into the circulation. Otherwise, it's not released. So when you check it in the circulation, you will find it to be low, okay? So if you take a look here, we have a recurrent bacterial and, oh, I was exposed. Enteroviral infection. I'm kidding, I was not exposed. So Agama Glubulinemia. So what antibodies are lost? All of them. Including which one protect your mucosal membranes? Which antibody protect your mucosal membranes? IgA, excellent. So when you lose IgA inside of the GIT tract, to be more precise, inside of the intestine, which lymphoid tissue do you have? Which lymphoid tissue exists inside of your intestine? Absolutely correct, Alicia. It's the Bayer's batches. Good. So this Bayer's batches are the lymphatic tissue located inside of your small intestine. Let's take a look at them. And these guys start secreting what? What they secrete, guys? Can somebody tell me what they secrete? They secrete IgA, okay? So they secrete IgA, and when they make this IgA, they help to defend you, okay? So they help to defend you. Do they secrete the IgA as a primer, as a one unit or two units attached with each other? This is important. Dimer, excellent. Excellent, it's a dimer. So dimer means it's like two units stuck into each other, okay? So if you take a look here, let me see, no, this is the wrong example. So the process of making IgA, you will basically have one IgA released and it will connect to another IgA, okay? And the area in which they connect to each other, what do we call it? Excellent, we call it the J chain. So let me send this and I will explain what I mean by that. So when you take a look at this area. You have the plasma cells making an IgA, well, one unit, and then two units connect with each other at this point. This point we call it the J chain. And after that it will be secreted, but it cannot be secreted without what? Without a polymeric Ig receptor, which will help it to be grabbed into it, and this secretory particle will allow it to go out, okay? So so remember, it's a long process. So all of it is happening in the Bayer's batches. Basically, let me tell you the whole process. An antigen will be detected by the M cells of your small intestine. It will be presented to the antigen presenting cells, which is the dendritic cells. And it is antigen presenting. Antigen presenting. So this is the antigen is presented to whom? The T cell. So the antigen presenting cells with the MHC will have this little antigen which will be represented to the T cell receptor. So the T cell receptor will be connected to the MHC through the antigen, and then he will start making cytokines. These cytokines and another type of connection will happen, which we spoke about previously, with the B cells, and that led to making the B cells more mature. So the B cells will go inside of your circulation basically, and they will make it up back to that region, basically back to the Bayer's batches, in which there will be plasma cells that will start secreting IgA that will bind using a J chain, and it will be secreted into your circulation. If you did not get all of that, it's okay. It's not our topic even. Our topic for today is to understand that entero, what does the word entero in Latin mean? Entero means intestine. Entero in Latin means intestine. Enteroviral infection after 6 months. So let's start with the fact that they are enteroviral. Enteroviral, completely correct. Why? Because all of the enteroviral disease, mode of transmission is fecal-oral. Please write a note about this. All enteroviral viruses are fecal-oral. That means if they are fecal-oral, think about it. Which antibody need to protect us against them? Fecal-oral, we eat them. So which antibody should protect us? IgA, obviously. So in case of X-linked Agama Glubulinemia, we lose also IgA. Thus, we are at high risk of developing enteroviral infection. Well, now important thing. What is enteroviral infection? Can you give us their names? Well, yes, of course. It's Coxsackie virus, poliovirus, and echovirus. Oh, yeah, exactly. Good. So, yeah, these are three. Echo, Coxsackie, and polio. Echo, Coxsackie, and polio. So, as you can see, after 6 months of age, so in the first 6 months of your life, you get all of the immunoglobulins from mama. So you will be totally healthy, you will not get sick. I'm kidding. You still can get sick, but you still you are protected from the IgGs of mother. Now we have a little question. What is the smallest immunoglobulin we have by size? IgG, excellent. What is the biggest immunoglobulin we have? IgM, excellent. So the smallest okay, logically, which one between these two will make it through the placenta to the baby? IgG, excellent. That's why the IgG goes from mother to the child, and you will have a reservoir of IgG for 6 months. So the findings will be as follows. You know that the B cells will not be mature, so they will not make it to your peripheral blood. They will be stuck to your bone marrow. Basically, this is your answer why there is no IgMs. Absent B cells in the peripheral blood, decrease in the immunoglobulin of which class? All of them. So what about the IgM? Well, the IgM is located on the B cell, but the question is there any B cell in the blood? The answer is no, you don't. Where are they? They are still stuck to the bone marrow. Okay? They are in the marrow. So you will not have any IgM or IgD in the circulation. So remember guys, inside of the lymph node, we had an area that was full with B cells. How did we call that area? Remember I told you paracortex had a lot of T cells and some area had a lot of B cells. Which area had a lot of B cells in the lymph node? It was the first class. Yes. It was the follicle and the germinal centers, exactly. So primary follicles and germinal centers will be absent because you do not have a B cells anymore. So live vaccines are completely contraindicated. Why? Well, if you give a live vaccine, you cannot make any form of immunity against it. It's true that these live vaccines, as we said, they are attenuated, which means they are weak. But even if they are weak, if you have zero immune system, zero fighting 0.000001, this one will win basically. Thus we never give live attenuated vaccine. Guys, I want one of you to tell me which vaccine is not attenuated. We do give the actual virus to the patient. In which disease we give the actual virus to the polio? No, not polio, it's adenovirus. Adenovirus leading to the pink eye. What about polio? What it can lead to if you give it to the patient? Polio lead to paralysis, okay? Anterior horn defect and paralysis. There is an attenuated vaccine for it, but it's attenuated. Attenuated means weak, okay? So, but we don't give the actual virus for them. So, but for whom we give the adenovirus, this is actually high yield. For whom we give the adenovirus? Yes, exactly, to the military. Only the army recruits. No, don't give it for civilians. Why? Because we give it for military recruits because we don't want them to get sick when they are in the war, you know? It just does not make sense to have a pink eye in the middle of warfare. So you make them have the disease before that. So, okay, the next type, so I hope this disease makes sense. It's quite simple, nothing difficult about it. They have a lot of biogenic infection, which is bacterial infection. Why? Because they have no IgG. They have enteroviral infection. Why? Because they don't have IgA. Okay? Now I will jump from this disease, which is number 1, to disease number 2. Why I will miss this one? Why I will not speak about selective IgA deficiency? I will, but I will speak about it a little bit later. I'm going to speak about this one now because it looks exactly the same as the first one in your questions. So I will help you to differentiate between the two. Common variable immunodeficiency, or CVID, we call it, CVID. It's a defect in the B cell differentiation. Most likely, we have no idea why it happens. So it may present in childhood. Make a huge note. More than 2 years, okay? More than 2 years. But usually diagnosed after puberty, but it cannot be less than 2 years. Increased risk of autoimmune diseases, bronchioctasis, I'll speak about why in a second, lymphoma, Synopulmonary infection. Let's start with this. So first of all, these patients, they have B cells or they do not. They do have it, but it's not differentiating. What does B cell differentiate to, guys? What does B cell differentiate to? B cell becomes another type of cell. How do we call it? Plasma cells. Plasma cells can make you IgAs and all of the other stuff. Good. So, if we speak all of the IgGs, exactly. So, common variable immunodeficiency, when you have this disease, basically you will not be able to differentiate the B cells. You already have healthy B cells, but you cannot make plasma cells outside of them. Yeah? So, this process is defective. So, you can have like naive becoming B cells, but you cannot have plasma cells. Here, the naive B cells cannot become B cells. Yeah? So the defect here is here. So it's no question about becoming a plasma cells. This will not happen as well. Okay? So in these patients with common variable immunodeficiency, they will not have plasma cells. If you don't have plasma cells, the function of plasma cells is to make immunoglobulin, so you will have decreased immunoglobulin. If you have less immunoglobulin, you will have recurrent bacterial and enteroviral infection. Shit, it sounds the same. It's exactly like protons. How can I differentiate? I will tell you just a second. Even these, like the characteristic symptoms they have, these also can be here. So this will not help you in the question. So they have a bronchioctasis, for example. What is the reason of a bronchioctasis? Recurrent inflammatory diseases of the lung. Guys, if you get the pneumonia one time, it's a problem. If you get it again, it's a big problem. But if you get it like 20 times, no, not 20 times, but if you keep getting it like 6-7 times, you get a process called the bronchioctasis. What is a bronchioctasis? Basically, if we imagine that this is your airway, you will have a ridiculous amount of mucus secretion inside. Your mucociliary apparatus will be damaged, so you lose your cilia, and you have damage to the wall. So this thing will become huge with a lot of mucus inside of it. So when you look at a CT of this patient, you will look at their bronchi and it will be huge. So let me show you. If I send you this, you can see that the size of the bronchus is huge, and there is this thing inside of it, the white stuff. Can anybody tell me what is the white stuff in here? Take a wild guess. It's It's basically a lot of mucus, okay? A lot of mucus. Good. So this is a bronchioctasis. Why bronchioctasis happens? Because of recurrent pulmonary infection, recurrent pneumonias, okay? Guys, how it looks like. See this thing? We call it honeycomb appearance, okay? Honeycomb appearance. In respiratory system, I will speak about it twice. This is one of them. So it looks like a honeycomb. So if you hear in the question honeycomb appearance, start thinking about the bronchioctasis. Good. So moving on. Yep. Okay, so also they can have lymphoma because their immune system is pretty much screwed. They also can have synopulmonary infection, which is basically recurrent sinusitis and recurrent pneumonia, which will be mostly bacterial. Yeah? Now, how can I differentiate between the two? So, I will do it like this. Agama, these patients have symptoms less than, more than 6 months. Mainly bacterial and enteroviral. Why enteroviral, guys? Can somebody tell me why enteroviral? Why people with the protons get enteroviral? Yes, no IgA. While the people with CVID, which is common variable immunodeficiency, when do they have the symptoms? More than 2 years. Mainly bacterial and enteroviral. Okay? The first disease have 0 B cells, 0 plasma cells. The second disease have low B cells, 0 plasma cells. That's what you need to know. You must know these two to be able to differentiate between these two conditions on your exam. So, okay, now since we have a little bit of peace between these two diseases, we can speak about the third one. So the third disease is a selective IgA deficiency. Where did we see it before, guys? Can somebody remind me, where did we see IgA deficiency? Exactly, the allergy, the anaphylaxis thing, yeah? Okay, so selective IgA deficiency, the cause is unknown, and I love when it's unknown because you don't have to know it. Most common, primary immunodeficiency. It's really common, and it can lead to one symptom that is important I will tell you about in a second. You don't have IgA. Where we mostly found the IgA, guys? Where did we find the IgA mainly? Mucous membrane. So you have higher risk of developing airway sickness, airway infection, GI infection, genitourinary tract infection, okay? So majority are asymptomatic, can lead to airway and GI infection. Autoimmune diseases, I looked it up, they don't know why. They don't know exactly why they have it, the autoimmune diseases. But the atopy and the anaphylaxis, this is important. So the atopy and anaphylaxis, what's up, what happens? Let's say we have this guy. This guy has an IgA deficiency. He needed a blood transfusion, and this guy told him, okay, take some of my blood. So he gave him some of his blood. What will happen? First exposure, mostly nothing, okay? First exposure, mostly nothing. So, okay, this guy went away, he died, all good, okay. New guy, this guy needed the blood second time. After the exposure the first time, all of his cells have been exposed to the antigen, which is what? The IgA, yeah? So now on the second exposure, when they get exposed to this, what they will have? Anaphylaxis, yeah? They get exposed to this and boom, anaphylaxis, anaphylactic shock. I have a question, guys. Can someone that was exposed to the blood for the first time in his life never had a blood transfusion before, get anaphylaxis from an IgA blood product. He never had any blood before. I'm asking you this because they do ask this. Yes, amazing. Where did they, okay, so, well, logically question, how? If they were never exposed to it, how did they even see an IgA as an antibody? I will tell you. Some food product that we consume do have an IgA-like material. And due to the process of the immune mimicry, we will start to formate antibodies against that, well, possible antigen. Yeah? So with autoimmune mimicry, when we get exposed to a real IgA, we will have these antibodies that will attack the IgA and destroy it. During this process, guess what will happen? Anaphylaxis. For those who did cardiovascular system with me, during anaphylaxis, what happened to the systemic vascular resistance? Low. Excellent. So what happens to your heart rate and cardiac output? High. Excellent. And if we speak about what is going to happen to your preload of your left ventricle, the preload? Low preload, low preload. Why low preload? Because your veins are becoming dilated. When your veins are becoming dilated, they will pull the blood backward, yeah? It's not only the arteries dilating in anaphylaxis, everything is dilating, okay? What is the treatment of anaphylactic shock? Anaphylactic shock, what do we give? Epinephrine, excellent. What about septic shock? Norepinephrine, excellent. Norepinephrine. What about if I tell you cardiogenic shock? We can use dopamine, but mostly dobutamine. Dobutamine. Excellent. Good. So, yeah, these patients will have anaphylaxis to an IgA in the blood products. So they have low IgA with normal. All of the other antibody will be completely okay. It's only the IgA that has the problem. You told me, guys, that IgA is located in the mucous membrane, which are like your GIT, urinary tract, respiratory system, that increase the risk of airway and GI infection. But guys, guess what? The most common infection you can get is this guy, Giardia. She's cute, I have to say. So take a look. Giardiasis. Giardia lamblia. Look at it. Cute, huh? She's smiling at you. So, do we have it often in the water, guys? Is it often in the water, this thing? I mean, in the US, is it often in the fresh water? Does it exist? Yes. Okay, it exists. So it exists often in the water, freshwater sources, and yeah, you drink it. And after you drink it, it does something interesting. It clogs your villi. So basically, if this is your intestine, oh my God, what is this? Okay, if this is your intestine, just I'm clearing this board. If this is your intestine, it will come and it will clog the intestine. So if it's clogging the intestine like this, basically there is millions of it that enters and they proliferate really quick. You will not be able to reabsorb the water. If you will not reabsorb the water, what will happen to the water? It will go out. Where it will go out? To the feces, yeah? That leads to diarrhea. Yep, watery diarrhea, excellent. So is there any invasion of the intestine? Is it invading the intestine? The answer is no. It's not invading the intestine. Why the water invasion is super important? Because if it was invading, it becomes bloody. But it's not invading, thus it's watery with foul smelling. Yeah, what does it mean, foul smelling? Foul smelling means it contains fat. Why it contains fat? Because you cannot reabsorb fat. If you cannot reabsorb fat, you cannot reabsorb what else we reabsorb with fat. What is fat soluble? What else we will not be able to reabsorb? Yes, vitamins. Which vitamins are fat soluble? Which vitamins are fat soluble? Just write one of them. The fat soluble vitamin are A, D, E, and K. So you can have a deficiency of all of them. Anyway, let's go back to our topic. Increased susceptibility to Giardia because you don't have an IgA to protect you against it. And it can cause a false negative celiac disease test. What does that mean? Well, in the celiac disease testing, we do check the IgA. So we do check IgA transglutaminase. Okay? So guys, think about it. If you have an IgA deficiency, will you have an IgA transglutaminase? You will not. Yeah? So if you do not have an IgA transglutaminase, you will get a false negative. What does false negative mean? It's negative. The test is negative, but in reality he's positive. So he's a false negative. Yeah? Because in reality he does have celiac disease. Okay, and these are all of the B cell disorder. Let's speak about the T cell disorder. So for the T cell disorder, we have thymic aplasia, which is 22q11. What does a Q mean? A Q means the long arm of a chromosome. Basically, if a chromosome is like this, it has a short arm and a long arm. The long arm, we say it Q. The short arm is P. Okay? So 22q11 microdeletion. For testing microdeletion, I will tell you later, we do a test called FISH. You did not study that yet. You don't have to know it. Failure to develop third and fourth pharyngeal pouches. What are these? You did not study these yet. You don't have to know it now. But these pouches basically are pouches located in the embryo. So we are going to study it in embryogenesis and the reproductive system. So when you don't have this, you will have absent thymus and parathyroid gland. If you don't have thymus, you will get, well, defect of what? What the thymus did for us. What is the function of thymus? I hope someone will say the production of T cells. Come on, I'm waiting. I'm not going to continue the class until someone tell me what the thymus does. Yes, T cell maturation, exactly. Maturation of the T cell. It's never, ever, ever the production. The production of the T cells, where does it occur? Excellent, it's the bone marrow. Yes, absolutely correct. Okay, so Vdg syndrome, they have thymic, parathyroid, and cardiac defect. If you do not have parathyroid gland, what electrolyte disturbance you will have? Low parathyroid hormone, low calcium. Excellent. Low calcium, because your parathyroid hormones, your parathyroid gland is gone. So your calcium will be low. Your phosphate will be high. Why? Because the parathyroid hormone normally has excreted the phosphate. Now, when you do not have it, you will have hyperphosphatemia simply. The cardiac defect, you will have something called conotroncal abnormalities. It's due to the absence of the pouches. We'll explain what are these in a second. It has two forms, this microdeletion, as of a disease leading to thymic aplasia. The first one is Vdg syndrome, and the second one is velocardiofacial syndrome. So what is this? This one, basically, these children will have mainly face stuff. So they will not have thymus, but they will not have like a palate, face, stuff like that. But the main thing is their parathyroid gland will be intact. I feel that I said something wrong here. Just one more time. Granuloma syndrome, they don't have a thymus. Villofacial syndrome, they do have thymus, but they have the facial defect and the cardiac defect. Okay? Also, the Granuloma syndrome don't have parathyroid gland, so they have hypocalcemia. While the villofacial syndrome do have parathyroid gland, so they will not have what? They will not have the hypocalcemia. So let's take a look at this. See these guys? Yep, they can have some like defects in their faces. They remind me of other syndrome, by the way. Oh yeah, this guy. So basically they can have their palate damaged inside of their mouth up there, and they can have this basically jagged jaw, we call it, like the jaw going down, okay, and the cleft palate. It could be actually similar symptoms to the Giardia, but the main difference is the hypocalcemia, to be fair with you guys, and the immunity thing. Okay, good. So to speak about catch-22. Catch-22 is a mnemonic. So it includes cardiac defects, so conotruncal abnormalities. First of all, one of the conotruncal abnormalities include tetralogy of Fallot. What is tetralogy of Fallot? Can somebody tell me one of the symptoms at a time? Everybody tells one symptoms that he remember the most. In tetralogy of Fallot. Not symptoms, I mean defect, one of the defects. There is 4 defects, everybody choose one. Okay, somebody wrote pulmonary stenosis. This is the most important one actually. VSD, that's correct, not ASD. ASD is inventology of Fallot, not tetralogy of Fallot. So they have VSD, right ventricular hypertrophy. Coarctation of the aorta is internal syndrome. It's not in tetralogy of Fallot. Overriding aorta. So let's count these. Pulmonary stenosis, right ventricular hypertrophy, VSD, overriding aorta. 4 things. In case of a truncus arteriosus, guys, in case of truncus arteriosus, we had a defect in the formation of what? We had a defect in the formation of something called aortopulmonary septum. If that aortopulmonary septum is not existing, you get truncus arteriosus, which is basically one big vessel. Yep, one big vessel that allows the passage of the blood to both the aorta and the pulmonary trunk. But I have a question though. If this aortopulmonary septum was formed, it was okay, it was there, but it failed to spiral. It did not spiral. Which disease you will have if you did not have a spiralation? Excellent, Alicia. It's a transposition of the great vessels. So you can get the transposition of the great vessels if you have failure of a spiralation of the aortopulmonary septum. But if you have basically aortopulmonary septum do not exist at all, he's absent, you will have truncus arteriosum. Okay? So basically what I'm trying to say that this one, which is truncus arteriosum, you will have no aortopulmonary septum. Okay? Does not exist. While in the transposition of the great vessels, you do have it. It exists. But it did not spiral. So aortopulmonary septum is there, but no spiralation. Okay? So back here, they can have also abnormal faces. We just took a look at that. Thymic aplasia, so you will have T cell deficiency. That lead, as we said, T cells are mainly helpful for us to fight viruses. So you can get recurrent viral fungal infection. Also, you can have a cleft palate, hypocalcemia, secondary to parathyroid aplasia, which can lead to tetany. I just want to speak really quick about Fostex sign and Trusay sign. So what is the Fostex sign? Basically, this patient, look at this guy. He has hypocalcemia. So what will happen if you tap his facial nerve? See it? He will start to wink. That's the Fostex sign. Now he's going to test something called the Trusay sign. Look, when you inflate the blood pressure cuff, look what happens to his hand. It has flexed. See? He's closing his hand on the inflation of the blood pressure cuff. It's symptoms of, yeah, see it? Look. Oh yeah. This is Trusay sign. Okay. Next. This patient will have less T cells, less parathyroid hormone, and less calcium. Thymic shadow is absent on chest x-ray. They will not have a thymic shadow. Okay. Other disease that will not have a thymic shadow I will tell you about today is a SCID. So the next disease I'm going to tell you about is something called interleukin 12 receptor deficiency. Interleukin 12 receptor deficiency is due to decreased T helper 1 cell response. It's autosomal recessive disease, and I will show you just one thing. Just a second. Yep. So I'm going to tell you one thing about the interleukin 12. Interleukin 12 is super important information of granulomas. Remember, you have caseating and non-caseating granulomas. Caseating granulomas in infectious disease, non-caseating granulomas in autoimmune diseases. If we want to speak a little bit about basically, just let me go back here. If we want to speak a little bit about the interleukin 12, it's unfair to speak about it without showing you this picture. So, as you can see, the T helper cells secretes interleukin 12, which help you to activate T helper 1 cells, which lead to activation of macrophages and eventually lead to formation of something called a granuloma. So a granuloma formation takes some cytokines to do. It is a process. Okay, so that process takes a few steps. It's not one step. You will have like first things, second things. It's quite few steps. I just wanna find the exact picture. I cannot find it here, but I highly believe that it was in the pathology section in first aid. But anyway, I'm going to draw it myself. So if we were to speak about the interleukin 12 deficiency, this patient will have less T helper 1 cell response as you saw above. And that will lead to absence of formation of a granuloma. Remember, in TB, what was the function of a granuloma? Basically, it was to contain the disease at one location. So we have the TB, the Mycobacterium, and it was what has been done to it. It was engulfed by a lot of macrophages, and it was just sitting in the middle. This is the Mycobacterium tuberculosis. Why cannot the macrophages kill it? They cannot kill it because it has something called the cord factor. The cord factor prevents the death of the Mycobacterium. Okay. So after the formation of this, and how it's maintained? It's maintained by something called TNF-alpha. So if you use a TNF-alpha inhibitor, the TB will disseminate, basically. Excellent, I found it. So you can see here an antigen presenting cells, and this is the antigen. Let's imagine tuberculosis in this case, okay? TB, Mycobacterium tuberculosis. So you have a secretion of interleukin 12. That primes the T helper 1 cells, which starts secreting interferon gamma. That interferon gamma activates the macrophage, and that macrophage starts secreting TNF alpha that lead to what? TNF alpha lead to the calling of more macrophage, which will start surrounding the antigen. So in case if you use a TNF alpha inhibitor, what you will have, this patient will not be capable of enrolling the mycobacterium anymore, and you will get a disseminated disease. Okay, let me ask a logical question. If you have an interleukin 12 deficiency, will you be able to form a granuloma? Yes or no? Impossible. Yes, you are completely correct. It's impossible to form a granuloma. So can you control tuberculosis in this case? Can you make a granuloma around tuberculosis to prevent him from infecting other tissue? Can you make a granuloma? You cannot. If you cannot make the granuloma, you will have a disseminated infection. What I'm trying to say that in case of interleukin 12 deficiency, what will happen to you that you are going to develop a case of disseminated TB, even if you had other types of immune system cells functional. So take a look here. They write disseminated mycobacterial and fungal infection because these were normally maintained by what? By granulomas, and now you cannot form any granuloma. It may present after the administration of the BCG vaccine. Why? What type of vaccine is BCG vaccine, guys? It's a live attenuated vaccine, so it can become reactivated. Okay, so this patient, obviously, as we saw in the previous picture, will not have interleukin 12, will not have active T helper 1 cells, will not have interferon gamma. Most common cause is Mendelian susceptibility to mycobacterial disease. So some patient will be having a lot of TB in their family, you know? Be like, yeah, my father had TB, I had TB, my grandchildren had TB, everybody in my family had TB. Why? Because they could not engulf it. Basically, guys, a lot of us were exposed to TB at some point in our life. But our immune system is dealing with it good. But some patient will not have the adequate immune system to be able to deal with it, which can precipitate to disseminated infection. Okay? So now I will give you guys 10 minutes break. And after the break, I will come back, finish up with these things and this patient. Okay, guys. So see you in 10. I cannot find the document. Oh yeah, here it is. Okay. So speaking now about Ataxia Telangiectasia. No, I feel like something is missing. Yes, Jobs syndrome. Yeah, speaking about something called Jobs syndrome, I want you to know it's one of the autosomal dominant diseases. So somebody asked me the other day, how can I know the autosomal dominant disease? I keep forgetting them. So there is a little song you all must memorize. You will send it to you now. Please do memorize it because it will save you a lot of time. Okay? So there is a song here. It says von ls Rgm en. Anyway, so you will memorize this song, and that's everything that is required from you basically, for the step 1 at least. There is another song for the X-linked recessive disease, which you also need to know, and yeah, it's a little bit different. This one, it's a bitsy hunter name was Lish Fabry. Anyway, I don't have the voice, so I will not humiliate myself more. Okay, I don't share my screen. Let me share my screen. Can you see my screen? So you guys were basically just listening to me singing, not even seeing my screen. Okay, good. So let's take a look now. So we have something called autosomal dominant hyper IgE syndrome, Jobs syndrome. So this patient will have a deficiency in the Th17 cells, which is also called what? It had another name, guys. Do you remember the name? Th17. Nobody know the name of Th17 cells? Okay, well, these guys basically help in the pro-inflammatory response. Okay, let me make sure that I'm recording. Yes, I am. So yeah, exactly. Good. So let's take a look here. So we have here the Job syndrome. They induce the neutrophils. Exactly. Good. So if they do not exist, if you don't have normal T helper 17 working, will you have normal neutrophil function? The answer is no. The neutrophils will be impaired. They will be working bad. Yeah? So deficiency of the T helper 17 mostly happens due to a genetic defect, which is a gene called STAT3. Okay? So this gene is called STAT3. Impaired recruitment of neutrophils to the site of infection. So this patient can have, because you don't have the T helper 17, you cannot recruit the neutrophils, and thus you will have something called cold abscesses. What is cold abscesses? This is really important concept because they do explain it, but they don't basically tell you cold abscesses. They don't tell you the word cold abscesses. They tell you that, oh, the patient has like a focus of enlargement of a bus that has no neutrophils inside of it. Okay? Just like an abscess with liquid material inside of it, like the bus, but it has no neutrophils. If it has no neutrophils, that means it's a cold abscess. Okay? That's a cold abscess if it has no neutrophils. Why? Because neutrophils lead to the inflammatory response. So if you have a cold neutrophils, will you have the signs of inflammation inside of it? Yes or no? If it has no neutrophils, will it have signs of inflammation inside of the abscess? The answer is no. Yeah, they will not. So there is something important about Job syndrome that only exists in two diseases. Thus, if you see it, it makes your life easy. The first thing is something called supernumerary teeth. Okay? So you can see, oh yeah, he has a lot of teeth. Yeah? Supernumerary teeth. When you see this, it only exists in two diseases. I mean, yeah, you know, it's this picture that people used to post on Facebook, and everybody was like, Photoshop fake, Photoshop fake. No, it's not fake, and it's not Photoshop, it's real. So this is Job syndrome. Only two diseases can have this problem. Okay? The first one, so what I want to write now is something like this. Supernumerary teeth can only exist, can only be in one, Jobs syndrome, not Steve Jobs, and two, so something called Gardner syndrome. Gardner syndrome are patients that have FAB, which is familial adenomatous bulbosis, plus this disease, which is the supernumerary teeth. Okay? So supernumerary teeth only exist in these two diseases, Job syndromes and Gardner syndrome. That's it. Okay, so it's highly characteristic of the disease. The moment you see it, done. You have a diagnosis. So they have baby teeth, coarse faces as well. Let me show you that. Yeah. See the picture, guys? Actually, they don't look that. Yeah, this one. Coarse faces. And yep, looks more friendly. Okay, this is the coarse faces, and they have one more thing. They have this dermatological problems like eczema. They can have eczema of their skin, and obviously it's an IgE, hyper IgE syndrome, so it will be IgE. Okay, so they will have high IgE, and they can have also bone fracture from minor trauma. So they can have bone fracture from minor trauma. So they get hit and they get a fracture. This is not characteristic of this disease, since minor fracture leading to a trauma can also be seen in case of osteogenesis imperfecta. So in case of Rgm syndrome, you have IgE. Which cell is highly associated with IgE? You guessed it, eosinophils. Learn the A, B, C, D, E, F to get a job. Yeah? Okay, good. Chronic mucocutaneous candidiasis. It's due to T cell dysfunction, impaired cell-mediated immunity against the candida. Guys, someone who has HIV, one of the first symptoms they can have is something called candida. What is candida? Candida is a fungi. So it's important to know one more thing about it. In the slang way of saying it, we say thrush. Yeah? We say that, oh, that girl has a yeast infection. What is yeast infection? This. So she has a, so you can see here the thrush. Yeah? This thrush is caused by candida. Guys, if I try to scrape it off, it's scrapable or not? Or it's sticky? Is it sticky or it come off if I try to scrape it off? It's not sticky, it scrapes off. If you take a, well, you can do that, but basically if you get something and try to scrape it off, it will scrape off. That's the thing. Scrape, tongue scraping. Yeah. So yeah, basically if you try to use this retractor to scrape it off, it will come off, no problem. See this guy? He's trying to get it off his tongue and it works, no problem. But in case of hairy cell leukemia, for example, leading to tongue manifestation or cancer of the tongue, it will not be scraped off. Yeah? So this is a clinical examination finding. If it scrapes off, all good. If it does not scrape off, big problem. So let's go here. Okay, so they can have candida, a classic form caused by a defect in IRE. Guys, do you remember where we saw the IRE? We saw the IRE in a condition related to which form? Yes, they have so many autoimmune diseases, but can you tell me please, during which process defect we had it? Which process was defective, and because of that defect we got IRE disease? Remember? Something related with this guy, thymus. Negative selection, guys. Negative selection. When you have a problem in the negative selection with the autoimmune regulator, that will lead to IRE. What is IRE? A lot of autoimmune diseases, as you said. Autoimmune diseases against so many glands. For example, hypoparathyroidism, adrenal insufficiency, recurrent candida infection. Also, they can have chronic mucocutaneous candidiasis. So these two are due to autoimmune dysfunction, and the other two are due to the fungal infection because you have a defect in the T cell. Remember, T cells used to basically protect us against fungi and viruses. So this patient can have persistent non-invasive, this is super important, non-invasive candida albicans infection of the skin and the mucous membrane. Absent in vitro T cells proliferation in response to candida antigen. Absent cutaneous reaction to candida antigen. Let me explain. So, if you get a culture, okay, and you want to check if this patient have this disease or not, if he has chronic mucocutaneous candidiasis or he does not, what do? You bring a dish, this petri dish basically, yeah? Let me do that. You bring this petri dish. And you fill it with T cells, a lot of T cells. After putting a lot of T cells, you add the what? The antigen. After putting the antigen, What is the antigen here? It's the candida, yeah? So normally, if we do it in a normal human being, it should be destroyed, yes? But if it was not destroyed, that means your T cells are dysfunctional. They are unable to kill it in vitro. In vitro means outside of the body in the laboratory. That's why I told you about a Petri dish, yeah? Also, if you do this cutaneous test, which looks exactly like a TB test, basically, they will test negative, okay? They will test negative for it. Why? Because they cannot have a T cell response. And the skin reaction is fully a T cell response. Okay. So the next thing here is about other forms of immunodeficiency. So we spoke about the T cells, we spoke about the B cells immunodeficiency. Now we speak about the combined immunodeficiencies. So the first one is severe combined immunodeficiency. Severe type includes defects in the interleukin-2 receptor. And guys, do you remember what was the function of the interleukin-2? Hot T bone stick. What was the function of the interleukin-2? Hot T. What was the T? Yeah, exactly, T cell stimulation. So, what I'm trying to say, if you have interleukin-2 receptor defect, you will have no normal T cell stimulation, yeah? Which can lead to no cellular or humoral antibody response. And eventually, you will not have basically antigen presenting cells and B cell activation, which can lead to both B cell and T cell defects, which mean you have severe combined immunodeficiency. Okay, so several types include the defect in the interleukin-2 gamma chain. It's the most common. It's X-linked. Remember, receptors. Yep. So the defect in this receptor is X-linked. Yeah, there is one more cause. It's called adenosine deaminase deficiency. It's autosomal recessive. I would like to show it for you guys. Be like, yeah, we never saw it before. Well, you are right. We did not do biochemistry yet. By the way, according to the book, biochemistry is the next system. Guys, I did not choose this. I have to say, biochemistry is a little bit tough. But anything else afterward, I promise it will be much easier than anything you already finished. Some people say CNS compared to biochemistry and immunology, it's a piece of cake. So, if you take a look here, this is your adenosine deaminase. So in this disease, it will be blocked, yeah? Well, you are like, okay, it will be blocked. What is the big deal? Well, when it's blocked, which substance will accumulate? Look at this graph. Which substance do you think will accumulate? The arrow goes here. So if this is defective, the ADA, you will have accumulation of the adenosine. Okay, so the arrow goes to this side. So you cannot form adenosine, so you will have a lot of adenosine. Okay, a lot of adenosine. I want to tell you something about adenosine. He's really toxic. Okay, remember adenosine was a vasodilator. Wow, that was perfect. But if it's inside of the cell, he's toxic. So that will lead to death of which cells? Let me tell you, all of the lymphocytes. So adenosine is highly toxic, and its accumulation will lead to lymphocytes destruction. The destruction of the exactly. It's toxic to the lymphocyte. So that will lead to destruction of the lymphocytes. Excellent. So moving on back to our skid. No. So yeah, they write interleukin 2 receptor gamma chain defect, adenosine deaminase deficiency, and finally Rgm mutation. What is this Rgm mutation? Guys, do you remember the Vdg recombination? I have a question first of all. Vdg recombination, we know that it occurs in the antibody. Does it happen on the Fc portion or the Fab portion of the antibody? Where does Vdg recombination occur? Is it in the Fc portion or the Fab portion of the antibody? Remember, please, the antibody looks like this. This portion down here, we called it the Fc portion. And we have light chain, light chain, light chain, and this portion up here, we call it the Fab portion. So the defect will happen at the Fab portion. Okay, the Vdg recombination defect will happen at the Fab portion. So there is failure to thrive in this patient, chronic diarrhea. Why chronic diarrhea? Because they get Giardia. Okay, they can have thrush. Why thrush? Because they have T cell dysfunction leading to Candida. Recurrent viral. Why recurrent viral? Because they have T cell dysfunction. Recurrent bacterial. Why bacterial? Because they have T cell dysfunction. Recurrent fungal. Why they have fungal? Because of recurrent T cell dysfunction. Recurrent protozoal. Why protozoal? Because they have recurrent B cell dysfunction in addition to lacking of IgEs in addition. Yeah. So the finding, basically there is some test called T cell receptor excision circles, and they will be absent. It's just a biochemical test, and it will be decreased. And in the US, they test every single baby for it. So it's a part of the newborn screening thing. In this patient, you don't have a T cells. So guys, if you don't have a T cells, will you have a thymus or not? No T cells. Will you have a thymus? No, you will not. Okay. So if you have no B cells, will you have tonsils? Will you have tonsils? So you will not have tonsils. They will become atrophied as well. Excellent. Good. So they will not have tonsils as well. So this is, in this disease, they don't have anything. That's the idea. Absence of thymic shadow, germinal centers in the lymph node biopsy will be absent, and T cells will be absent in the flow cytometry. So they have nothing. So Ataxia Telangiectasia is a different disease. I will be speaking about it, actually the whole thing again when I explain biochem. It's a defect in the ATM gene, okay? So they will lead to failure to detect DNA damage. So I'll write a note, if you cannot detect DNA damage, you have higher risk of developing a mutation, and you will have failure to add on it, you will have failure in the repair mechanism. Which repair mechanism? You have defect in it, non-homologous end joining. Non-homologous end joining. You are like, what the hell is that? Well, if you open the 4th page of your book, you can find it. Just a second. 1, 2, 3, 4. Oh, sorry, the 6th page. So you can see here non-homologous end joining. This one, yeah? It's highly associated with ataxia telangiectasia. You must know this factoid. Basically, if you have a break in your DNA on the double strand, you need to rejoin it. So this rejoining process, you just do attach this end to this end, attach this end to this end. This is the end of the story. So you do not add, you do not remove, you do not try to fit it in any way. You just put the two ends against each other and that's it. Okay? So yeah. Un momento, por favor. Yep. Okay, you can see this here. So failure to halt the progression of the cell cycle, so you can get many mutations. And these mutation, can they be repaired? No, because one of this pathology main things that you have a defect in the repair of the DNA. Okay, so autosomal recessive disease, they have this triad, a lot of A's. They have cerebellar defect, that's the ataxia, spider angiomas, telangiectasias that blanch, make a note about that, their telangiectasias blanch. They disappear if you press on them. And they can have an IgA deficiency. If you have an IgA deficiency, which infection can you get from the water? From fresh water, after a camping trip, giving you foul-smelling diarrhea and vitamin D deficiency. Giardia, excellent. So, yep, Giardia, absolutely correct. So, increased sensitivity to radiation, this is super important because these patients have failure to repair. I told you, they cannot repair the damage in their DNA. Yes? They cannot detect the defect, they cannot repair it. So you want to give them as least damage possible for their DNA. So try your best not to expose them for, try your best not to expose them for what? For radiation, okay? Yep. So you limit the radiation exposure. Okay. So the next thing, it goes something like this. I'm really sorry, I have to quit this. Okay. So they also have an increased alpha-fetoprotein. This is a factoid, you must know it. They also have a decrease in many antibodies, IgA, IgG, IgE, as you can see. They have a defect in the repair, so they can have this leukopenia or cerebellar form of atrophy, which can lead to ataxia. And the next thing will be increased risk of lymphoma and leukemia. So lymphoma, leukemia, both of them sucks. Why they have that? Because they have a defect in the repair mechanism, okay? So they cannot exert the repair mechanism that lead to them to getting this pathology, okay? So Rgm Syndrome, most commonly due to defective CD40 ligand on the T helper cells. So that their T helper cells, how do we call when the CD40 connect to the CD40 ligand? It had a name. How do we call that? Like when they connect with each other. Because we had two signals. We had this primary signals and we had this signals. Which was what? Which type of signal was it? If you forgot what I'm speaking about, I'm basically speaking about where it is. Yeah, about this. Remember, we had the primary signal here, and we had this signal. Yes, the co-stimulatory signals. Absolutely correct. So, remember, the co-stimulatory signals was for the sake of activating the B cell. Yeah? So, if you take a look here, you can see this patient have what? This patient have a defect on the communication of the CD40 to on the T helper cells, which connect on the CD40 on the B cells. So the class switching is defective. Guys, what is a class switching? Can somebody tell me what is a class switching? Class switching is converting exactly, excellent, IgMs to another type of antibodies. Excellent. So, good. So, yeah. That means you will have a normal or high IgM while the other antibodies are absent. Yeah? So it's an X-linked recessive disease. So far, which disease were X-linked? Well, the interleukin 2 receptor subtype of the SCID was what? X-linked. What else? We also had the hyper IgM. We also had the X-linked Proton's Agama Glubulinemia, correct? So you can see many of these diseases are X-linked. And we only had this autosomal dominant, so keep that in mind. So I want to highlight something, guys, I forgot to mention regarding SCID. Have you ever heard about the bubble baby? Bubble baby. These children are stuck, yes, this guy. So these children are stuck into a bubble. If they get outside of the bubble, they might die. Why they might die? Because any virus can kill them, yeah? So you cannot get anything from the outside of environment to them. So these are the bubble babies. Babies with this kid. So let me send you this. Okay. So the next thing, okay, you have hyper IgM, but the other antibodies are absent. So you can get severe biogenic infection because you don't have a proper antibodies inside of your circulation. You don't have normal responses. So you can also get opportunistic infection with PCB, pneumocystis, cranny, cryptosporidium, which lead to diarrhea, and CMV as well. Okay, so pneumocystis lead to pneumonia, cryptosporidium lead to watery diarrhea, and CMV, well, that's another story. It can lead to pancreatitis, basically, which is like inflammation of your colon. Okay, so you will have failure of the germinal centers to drop. Why? Because you do not have adequate IgGs production, so they will become atrophied. Okay. So notice, if you want to differentiate between the hyper IgM syndromes and the Proton's Agama Glubulinemia, these guys don't have IgMs in their circulation, while these guys have a lot of IgM in their circulation. The next disease is Wiscottard Syndrome. Wiscottard Syndrome is due to a mutation of the WAS genes. Leukocyte and the platelets are unable to recognize the actin cytoskeleton, okay? So they cannot recognize the actin cytoskeleton. That leads to a defect in antigen presentation, okay? So they cannot recognize the actin cytoskeleton, lead to defect in antigen presentation, leading to an X-linked recessive disease. Let me elaborate on that. So during the process of getting to an antigen and getting it presented into the cell, we have to recognize some pattern of it. After that, phagocytosis, and after that, presented. This process is not occurring in this disease, okay? So if it's not occurring, why it's not occurring? Because of a failure of cytoskeleton. So the cytoskeleton cannot get the antigen from, well, it can get in, but it cannot move inside. So it will fail to be presented to the outside. So that will get you recurrent biogenic infection. Also, I like this mnemonic. It says water, which reminds me of the WAS gene. Also, Wiscottard, thrombocytopenia, eczema, and recurrent biogenic infection. Do you remember which other disease we spoke about also had eczema, guys? Primary immunodeficiency with eczema. Which primary immunodeficiency had eczema? Excellent, it was Job syndrome. Yep, that's one of these questions from between the lines. Okay, they have increased risk of autoimmune diseases and malignancy. Okay, so they have decreased to normal IgGs, IgMs, and high IgEs and IgA. So they don't really know exactly why this happened, but it does. Fewer or smaller platelets. They have as well, we said about the thrombocytopenia, it was one of the water mnemonic. Remember, thrombocytopenia, eczema, recurrent biogenic infection. Okay guys, let's just take 6 minutes to freshen up. We'll come back, we finish this portion, it's really quick, and we finish this. Okay, so see you guys in 6 minutes. Hello. Hello everybody, welcome back. Let's finish this up. So we have the last type of defects, last type of a primary immunodeficiency. So we spoke about the B cell disorders, T cell disorder, and we spoke also about the combined cell disorder. Now we speak about disorder that do not exist in any of these. It's disorders of the granulocyte. Okay, what is a granulocyte? A granulocyte is basically subdivided into 1. Eosinophils, 2. Basophils, 3. Neutrophils. Neutrophils is the most important because it helps us to defend our body against bacteria. So the first disease I'm going to speak about is said, we call it leukocyte adhesion deficiency. In case of a leukocyte adhesion deficiency, you will have a defect in basically this leukocyte adhesion deficiency, which is, we also call it the integrins. You are like, I've seen this before. Where did we see this before? We saw it in pathology, guys. So it was super important in pathology because if you remember, in the process of acute inflammation, we had the migration of the neutrophils from the blood here into the interstitium. Yes, to do basically the traveling from the bloodstream to the interstitium, we had to undergo some processes. For example, if you take a closer look to this area, you can see here is the guy, integrins. So these integrins basically will be defected. When they are defected, the neutrophils cannot make it from the blood to the interstitium. This process cannot happen. The adhesion process cannot happen. If the adhesion process cannot happen and you cannot transmigrate inside of the interstitium, what will happen to the number of neutrophil inside of the blood? It will be increased or decreased. Think about it. If you do not have migration of the neutrophils from the blood to the interstitium, what will happen to their level inside of the blood? Do you guys hear me? Oh wait, maybe. Oh yeah, they will be high. Yes, exactly, they will be significantly high. Yes, so when you cannot move them, they will be significantly high, and this is really characteristic of the disease actually. So yep. Anyway, we go back, speak about leukocyte adhesion deficiency. So if this process will be defected and you will not have normal adhesions, many disorders can occur. For example, you will have an impaired migration and chemotaxis in this disease. Basically, you will not have ability of the neutrophil to migrate into your interstitium. Thus, it will not be able to go and eat the pathogen inside of your interstitium. So they can have late separation of the umbilical cord. Remember, the umbilical cord normally separate like after a couple of weeks of birth. You are like, wait, don't we cut it? Yeah, we cut it, but we still have the stump, yeah? So the umbilical cord has this stump basically, yeah? And it's supposed to fall down after a couple of weeks, but if it does not fall down, it means that this patient might have leukocyte adhesion deficiency, which means he cannot have local inflammation and basically cannot lose the umbilical cord stump. They also will have an absent bus. Which other disease had a, well, basically abscesses with no neutrophils inside of it, called abscesses? Which other disease had cold abscesses? Job syndrome, exactly. Hyper IgE. Yep. So these patients will have dysfunctional neutrophils, which can lead to recurrent skin and mucosal bacterial infection. Why? Because the neutrophils is totally defective. The neutrophils are not able to work, so they will have recurrent bacterial infection. So increase in neutrophil in the blood will occur, obviously, because they cannot transmigrate. Remember, the neutrophils is inside of the blood. It wanna make it to the interstitium, but it cannot because you do not have the integrins, which is the CD18, which lead to the adhesion of the neutrophils to the walls. So absence of neutrophils at the infection sites lead to impaired wound healing. The next disease is called Chadiakagashi Syndrome. The main dysfunction in this disease is the transportation. So these patients will have a defect in the lysosomal trafficking regulator gene. So they will have microsomal dysfunction in the phagosome lysosome fusion. Let me explain what does that mean. So let's imagine that this is a macrophage, okay? And this is a little bacteria. So the macrophage comes and he eats the bacteria, yes? After eating the bacteria, he wants to do something with it. Well, it's inside of him, it's dangerous, can lead to digestion, indigestion, I mean. So what he need to do? He have some organelles inside of him, which is called the lysosome, which contain hydrolytic enzymes. So his function now inside of the macrophage is to connect these two together. He must connect the phagosome with the, he must connect this guy, which is the phagosome, into this guy, which is the lysosome, to form a structure that called the phagolysosome. To do so, he needs to connect many lines, many lines to lead to the connection. What do we call these lines? We call them microtubules, okay? So this is microtubules basically trafficking to bring the phagosome to the lysosome to form the phagolysosome. If this process is defective, you will never have a phagolysosome, So that can lead to a form of immunodeficiency. So they write defect in the lysosomal trafficking regulator gene. So you will have microtubule dysfunction in the phagosome lysosome fusion. So you can get many problems. Let's start with them one by one. Well, the first thing, obviously, you will get biogenic infection because you are not able to clear out bacteria normally, And you have the blame, progressive neurodegeneration. Let me explain why. If we say that you have let's say that you have this neuron, okay? A neuron, this is a neuron, body of the neuron. You have the dendrite here, and you have the axon here. You have the axon here. Okay, how does the information and the neurotransmitter make it from the soma or the body of the neuron to the axon, to the presynaptic cleft? A presynaptic cleft. How does the info make it from here to here? It needs some type of a transporter. This transporter, we call it microtubules, So these microtubules will connect, These microtubules will connect the soma of the, basically the neuron to the body of the neuron, as you can see, So if this will be defective, and this, well, basically this microtubules will not be working, as so, you will not have movement of the neurotransmitter, which can lead to what? Neurodegeneration, You also can get something called Lympho Hesterocytosis. Let me show you about this. It looks actually quite cool, I have to say. Just a second. So it's a histological finding. Yep, I like to call it cannibalism. What do I mean by that? Well, look at this macrophage. What it has inside of it. Guys, how do we call this cell? What is this cell? Have multiple cells, multiple nuclei. How do we call this? Don't be afraid of answering. Giant cell, it's correct. It has many basically like nuclei, but this is not a giant cell. Basically, this cell has neutrophils inside of it. Can you see the neutrophils inside? So it's a macrophage eating neutrophils, which does not make sense, yeah? So why this happen? It's characteristic of this disease because of poor microtubules formation. Want to see something cooler? Look at this macrophage. It's eating what? What are these cells with one big nuclei? What are these? These are basically macrophages eating lymphocytes, okay? So basically in this disease, the cells are eating other normal human cells, which is highly pathological and can lead to serious problem, you know? So let me send you a couple of pictures for you so you will get an idea about how this looks like. So all of these cells that has cells inside of the cells, we call that Lympho Hesterocytosis. Basically, your macrophages are eating other cells, okay? That's what you need to know. So, also these patients can have the following. They can have albinism. The question is why they have albinism. Well, I will show you. Come on. Okay, it's not zooming out. So let me show you why they have albinism. Well, inside of your skin, you have this striatum basale, which is the lowest most portion of your skin. Inside of it, you have some, well, you have many types of cell, but you also nearby you have melanocytes, which make what? They make the melanin. The melanin then makes it start going up, yeah, which give you the color of the skin. How it goes up? With the help of microtubules. So if you have a microtubule dysfunction, you will not have the myelin going up, which lead to the patient having albinism. Well, basically his skin looks so white. So if they ask you, do the melanocyte exist? The answer yes. He has melanocyte. He just have a problem trafficking the melanin. This is an important question. Again, in this disease, you do have melanocyte, you just cannot move them to the right location, okay? So the next thing is speaking about recurrent biogenic infection because of the inability to form the phagolysosome, and finally the peripheral neuropathy is due to the same reason of poor transmission of neurotransmitter. These patients can have giant granules in granulocytes and platelets. Why? Because the substance are coming inside, but it cannot be dealt with. So it will just accumulate, yes? Because you have an ability to form phagolysosomes in case of a granulocyte. Also, you have pancytopenia. This is important. If this is your bone marrow, inside of your bone, you have formation of all of your cells. How do they make it outside of the bone to the blood? The answer is microtubules. Microtubules are defected, so you will not have a lot of cells in your periphery, which lead to pancytopenia, okay? Also, you can get mild coagulation defect. Okay, because also you need some microtubules to form the fibrin mesh, okay? You can see a lot of stuff. They are speaking about microtubules. So microtubules tend to be super important. The last disease we are going to speak about is chronic granulomatous disease, which is due to a defect in the NADPH oxidase. Yeah? So this NADPH oxidase decreases the reactive oxygen species such as superoxide and decrease the respiratory bursts in the neutrophils, which lead to dysfunction in catalyzing some forms of the bacteria. It's an X-linked form of the disease. One more X-linked. more risk of catalase positive organism and recurrent biogenic infection, recurrent infection and granuloma. To understand this, we need to go back to this picture. So these patients tend to have a deficiency of this enzyme. So if this is defective, well, they will not have this. This will not be there. But with what they will have is this. You're like, how they will have that? Well, basically, this is a bacteria, okay? Bacteria produce hydrogen peroxide. Like, wait a second. Are you thinking about what I'm thinking about? Exactly. You can utilize the hydrogen peroxide that the bacteria has secreted to make bleach out of it, okay? And after making a bleach out of it, you can kill the bacteria that made it, okay? Except in one case. If the bacteria make the hydrogen peroxide, and then the same bacteria also make what? Catalase. If she does make catalase degrade the hydrogen peroxide, which is a problem. Why? Because if it catalyzes the hydrogen peroxide, you don't have hydrogen peroxide to make a bleach out of it to kill the bacteria. So you have risk of infection. And that's why in case of a chronic granulomatous disease, you can only be infected with a catalase positive organism, never with a catalase negative organism, okay? Because catalase negative, you will have H2O2 from it, you can form bleach and kill it. Where did the H2O2 come from? From the bacteria itself, okay? So next thing we have here, abnormal I cannot read this one. Dihydrorhodamine flow cytometry test. Decreased green fluorescence. I have to show you this, guys, because I got it on my personal exam. So I think it's specifically high yield. I got something close to this, so let's take a look. Yep, exactly. Exact same thing. Yep. Okay. So if you notice in this patient, I will teach you the flow cytometry a little bit later. But basically what they did give, not this one, just a second. This one. Yeah. So they give something like this, okay? And they started telling you that this A is healthy, okay? And you have patient basically B. What's up? He's sick. Why? Because the green one has moved. He has more fluorescence. Why? Because of the oxidative burst, not a Karen, basically. Okay? So, yeah, if it moves to the left, it means he's sick. Moves to the left, it means he's sick. Okay? Oh, I like this. This is important. This patient is here. His mother is not affected and she's here. Why she's not affected but she is having a lot of them? Well, basically because this disease is X-linked. So for women, it's less severe than men. Okay? So the last thing is, nitroblue tetrazolium dye reduction test. Basically, we put this nitroblue dye and it must be turning blue if there is basically if there is NADBX oxidase. If the NADBX oxidase, it will turn the tetrazolium blue. If it does not exist, it will not turn it blue. Okay? So if there was NADBH oxidase, it will be positive. If there was no NADBH oxidase, it will be negative, which means you have the disease. Okay? Yep. Guys, do you remember where we saw tetrazolium before? We saw tetrazolium in one more topic. Do you remember where that was? Tetrazolium dye. We saw it in the book somewhere in cardiology, if you remember. In the page about post-MI consequences. I told you about the tetrazolium stain of the myocardium infarction, which can stain the heart blue. This is a different pathology, but yeah, just keep in mind that it's a similar name, not to get confused, be like, where did I hear that from? Okay, so the last thing before we finish today, general stuff. If you have low T cell count, you are more likely to have bacterial or fungal disease. Sorry, bacterial or viral disease. Viral, that's okay, that's good. So bacteria, you might get sepsis, but this is not the main thing. You can get CMV, EBV, GC virus, VZV, chronic infection with respiratory or GI viruses. Don't worry about the name of the viruses now. Just know with each defect what is more likely to happen. Is it viruses or bacteria? The actual organism, we'll discuss them deeply and each one of them when we study microbiology. Fungal infection that you can get is Candida, but highlight please the word local, because in case of decreased granulocyte function, which is the neutrophils, you get systemic Candida infection. Also, you can get PCB, Pneumocystis jirovecii, which is highly seen in COVID. Sorry, not COVID, in HIV, because they are immunosuppressed and it only affects the patient when their CD count is less than 200, not this PCB. So, Pneumocystis pneumonia, yeah, or jirovecii. As you notice, why I mistakenly said COVID, because the finding on an X-ray look typical to COVID, okay? But it's not COVID. Also, cryptosporidium, which can lead to diarrhea in patients who are immunosuppressed. So, like with T-cell dysfunction, like HIV patient, yeah? B-cell dysfunction, on the other hand, as you can see, all of these are bacteria. Please shine my skis, which are Pseudomonas aeruginosus, Strep pneumonia, Haemophilus influenza, Neisseria, E. coli, Salmonella, Klebsiella, and group B strep. Notice, all of these are bacteria. We'll speak about each one of them when we discuss microbiology, but for now, just know, decrease in the B cells mainly give you bacterial infections. And which type of viral infection, guys? Which type of viral infection? Enteroviral infection. So you can have a risk of enteroviral encephalitis because you don't have an IgA, yeah? Also polio, because it's a form of enteroviruses. And we know that live vaccines are contraindicated in this case. So you also can get giardiasis because you don't have an IgA. The next thing, if you don't have a granulocyte, what's up? What's going to happen? Some bacteria produce no serious granulocyte. Okay, so defect in the granulocyte, if you notice here, you have so many catalase positive organisms, like Staphylococcus. These organisms are catalase positive. Burkhardt-Fira, Sebacia, Pseudomonas aeruginosa, Nocardia, and Serratia. Your granulocyte defective, you can get these. Also, if you don't have a normally granulocyte functioning, you can get systemic, not local, Candida, Aspergillus, and Mucor. Finally, can someone tell me if I have a defect in the late complement activity, which type of disease I can have? Late complement. Late complement tend to form Neisseria. Yes, excellent. Neisseria infection. So low complement encapsulated species with early complement deficiency. Also Neisseria with late complement. This is super important. You need to know that early complement can lead to recurrent biogenic infection. Late complement, Neisseria infection. Early complement also can lead to lupus. Please know about this. Okay. And here finally they write B cell tend to produce more bacterial infection, while the T cell make more fungal and viral infection. And that's it for today. So yeah, we finished for today. Tomorrow we'll finish up immunology and we'll be done. Great. So see you tomorrow, guys.